Welcome to This Explainer. Today, we're diving straight into the complex and frankly high-stakes world of medical coding guidelines. We're focusing on a concept that forms the very backbone of healthcare reimbursement and compliance. We are going to uncover exactly why specific sequencing rules are so absolutely vital to the entire system.
So, let me ask you something right off the bat. Could a single code, just placed in the wrong order, actually trigger a federal fraud investigation? Or, cost a medical practice thousands of dollars in a single afternoon? It sounds a little dramatic, I know, but in the realm of medical coding, the exact sequence of those alphanumeric characters tells the entire story of a patient's encounter. Getting it backward doesn't just confuse the narrative, it literally alters the financial and legal reality of the claim.
Here's our roadmap for this explainer. We're going to cover 1. The stakes of medical coding, 2. The golden rules of sequencing, 3. Inpatient versus outpatient sequencing, 4. Modifiers and maximizing reimbursement, and finally, number 5, the cost of noncompliance.
All right, let's get into it. Part 1, the stakes of medical coding. We usually just think of healthcare as doctors and patients, right? But there's this massive data infrastructure running the whole show behind the scenes. As coding expert Rachel E. Briggs points out, it is your absolute responsibility as a coder to make sure this data is accurate. Your abstracting skills are literally the foundation of the healthcare system's financial lifeblood. You aren't just typing in random numbers. You're translating complex medical narratives into a standardized electronic format that the government and third-party payers use to evaluate care, track epidemics, and distribute billions of dollars.
Navigating this whole universe of code sets takes intense precision. Different groups use completely different code languages. You've got CPT codes for the physician's actual procedures and ICD-10-CM for the patient's diagnosis. And every single electronic claim is heavily scrutinized for accuracy by Medicare Administrative Contractors, or MACs. If you don't sequence these codes exactly right, bam, the claim gets rejected, or worse, flagged for a pretty grueling audit.
Moving on to Section 2, the golden rules of sequencing.
Okay, so how do we actually get the sequence right? Well, the official guidelines give us really strict conventions. Take the etiology manifestation rule, for example. It brilliantly shows the domino effect of sequencing. If you put the manifestation, the symptom, first, the entire logic of the claim just completely collapses. It's basically like telling the payer that a cough caused the patient to catch the flu, which is obviously backward.
The rule here is rock solid. You absolutely must code the underlying condition first and then the resulting manifestation second. You'll literally see notes in the manual shouting code first and use additional code. So, say a patient has dementia caused by Parkinson's disease. You have to sequence the Parkinson's first and then the code for dementia. The manifestation code can literally never, under any circumstances, be your principal diagnosis.
And there is a famously strict exception to look out for: severe sepsis. If a patient is admitted with severe sepsis, your first instinct might be to put that first, right? Well, actually, scratch that. The guidelines explicitly demand that you sequence the underlying systemic infection first. The code for severe sepsis, that subcategory R65.2, can never, ever be assigned as the principal diagnosis. Your sequence has to tell the true clinical story. An infection happened, and severe sepsis was the result. Which brings us to Section 3, inpatient versus outpatient sequencing.
Let's look at how the physical setting completely changes the game. You simply can't apply the same logic to a multi-day hospital stay that you would to a quick clinic visit. For inpatients, we use what's called the principal diagnosis. That's the condition established after study that is chiefly responsible for the admission. But for outpatients, we use the first listed diagnosis. That's simply the chief reason for that specific day's encounter.
Because of this huge difference, the rules for uncertain diagnoses completely split. Imagine a patient comes in with severe chest pain, and the doctor writes down, "Rule out myocardial infarction," basically a suspected heart attack. In a hospital inpatient setting, the resources used to figure that out are massive, so you actually sequence that "rule out" as a confirmed heart attack for the principal diagnosis. But in an outpatient clinic, no way. You absolutely cannot do that. Outpatient rules say an unconfirmed "rule out" is sequenced just as the symptom, so you'd code unspecified chest pain. Same exact patient, same doctor notes, totally different sequencing rules.
All right, Section 4, modifiers and maximizing reimbursement.
So we've got the diagnosis sequence locked down, but what about the actual surgical procedures? This is where the stakes get really high.
When a surgeon does multiple procedures on the same patient on the same day, does the exact sequence of those CPT codes and modifiers literally dictate if a provider loses money?
The answer is a resounding yes. Here's why. Medicare applies a really harsh 50% discount to the second most expensive procedure done in the same session. Because of this, you always have to sequence the highest valued procedure first. Then, you tack on modifier 51, which is basically just a tag saying, hey, this is a secondary procedure, to the subsequent codes.
Let's put some real numbers to this. If a coder casually sequences a lesser procedure, say CPT 11402, before a more intensive one like CPT 11423, that 50% discount gets slapped onto the higher-paying code. Just by swapping the order of those two lines on the claim form, the practice loses exactly $17.71 on that single claim. That might not sound like a lot, but multiply that by thousands of claims across a year. The financial impact is absolutely massive.
And finally, Section 5, the cost of non-compliance.
So the math definitely proves why specific sequencing rules matter for revenue. But what happens if someone deliberately breaks these rules to pump up those payments? Well, intentionally misrepresenting codes is straight up classified as federal fraud. Things like unbundling, which is exploding a single comprehensive procedure code into multiple smaller ones to get paid more, or upcoding. These are serious violations, and they are monitored super closely by government watchdogs like the Office of Inspector General.
The ultimate golden rule here is documentation. There's a great example from the source material about a new coder, let's call her Susan. She gets a super bill for a $62 Medicare office visit, but the doctor hasn't written a single chart note yet. The doctor tells her, hey, I forgot the paperwork, just submit the claim anyway. What should she do? She absolutely must refuse. As a coder, it's your ethical duty to tell the physician that you cannot, under any circumstances, submit a claim without the proper documentation backing up the diagnosis and the sequence.
Think about that incredible responsibility the next time you sit down to abstract a medical record. The exact order you place those letters and numbers dictates the clinical truth. It drives the financial health of the whole facility, and it ensures legal compliance. Specific sequencing rules matter because, really, they are the fundamental language of our healthcare system. So if a single keystroke can alter a patient's history, dictate thousands in revenue, and trigger federal audits, are you giving your coding sequence the respect it demands? Thanks for joining me on this explainer, and keep that precision in mind every single time you code.